Um, Welcome. Okay, so you could give me a minute to hide this. Welcome. Now, in today's session, we'll be discussing about congenital heart disease. We'll be discussing about congenital heart disease, okay? And we'll start off by defining and looking at the pathogenesis of that. Then we'll classify the various forms of congenital heart diseases. Then we will focus on the Acyanotic shunt anomalies. Okay, so at the end, you should have understood the brief. Welcome all, my name is Wallace Munyeri, and I'm the redactor. Now, definition and pathogenesis. Now, congenital heart diseases are abnormalities of the heart or of the great vessels, that is the pulmonary trunk of the aorta, that are usually present at birth. They usually account for 20 to 30% of all birth defects, and they include a broad spectrum of malformations, which can range from severe anomalies, which are incompatible even with intrauterine or perinatal survival, to lesions that produce few or no symptoms. So they can range from asymptomatic to life-threatening conditions. Now, congenital heart diseases, the pathogenesis, they commonly arise from faulty embryogenesis during the gestational weeks 3 to 8, during which major cardiovascular structures usually develop. You can remember your embryology. The heart develops from the primitive heart tube, okay? If you can remember that, and if you can again remember that the primitive heart tube was formed by the fusion of the two endocardial tubes, which originated from the blood islands from the spranchic mesoderm of the retrograde mesoderm. Now, in most cases, the cause is unknown. Up to 90%, the cause is unknown, but the accepted etiologic factors include environmental exposures, including congenital rubella infection caused by the rubella virus, teratogens, also maternal diabetes, and genetic factors. Okay, they are implicated in the causation of congenital heart diseases. Now, genetic factors include specific loci implicated in familial forms of congenital heart disease and certain chromosomal abnormalities such as trisomy 13, 15, 18, and the Down syndrome and the Turner syndrome XO. Okay. Now, let's look at how to classify these congenital heart diseases. Now, they are usually based on their hemodynamic and clinical consequences. You can classify it into, let's say, two ways first. They can be shunt anomalies and non-shunt anomalies, okay? Then, under the shunt anomalies, they can be either left to right shunt anomaly, or the right to left shunt anomaly. Now, when I say right, I mean deoxygenated bloodstream. And when I say left, I mean oxygenated bloodstream. Now, in left to right shunt anomalies, oxygenated blood is moving from the oxygenated bloodstream to the deoxygenated bloodstream. So there'll be no cyanosis. So these are acyanotic. But in the right to left, the blood is moving from the deoxygenated stream into the oxygenated stream. So there'll be cyanosis. So these are cyanotic. That is just what. Then in non-shunt anomalies, these are also acyanotic because there is no mixing of deoxygenated and oxygenated blood. Okay, so that is what I've said for definition. And these non-shunt anomalies can be obstructive, just malformations which cause obstruction. We define that. Now, a shunt is just an abnormal communication between heart chambers or blood vessels. Now, Depending on the pressure relationships, shunts permit the flow of blood from the left to the right side of the heart, or vice versa. Okay. And let's look at cyanotic congenital heart diseases. These are now your right to left shunt anomalies. With those shunt anomalies, a dusky blueness of the skin, cyanosis, results because the pulmonary circulation is bypassed and poorly oxygenated blood collected from the venous system enters now the systemic arterial circulation. Now, examples of these include tetralogy of Fallot. This is very important. Transposition of the great arteries, also important. Tricuspid atresia, persistent truncus arteriosus, and total anomalous pulmonary vein connection. Okay, so if you can remember now the heart tube, the distal 1/3 of the bulbous cordis was known as the truncus arteriosus, and it was giving rise to the roots of the great vessels. Failure of it to septate or to undergo the conotruncal septation will form a persistent truncus arteriosus. And if it does not undergo spiraling, the conotruncal septation must spiral. That's septum, the conotruncal septum has a spiral outline. If it fails to spiral, there'll be transposition of the great artery. In that, the pulmonary trunk will now be receiving blood from the left ventricle, and the aorta will be receiving blood from the right ventricle. And also, if that spiraling occurs, but it occurs asymmetrically, not at the midline, there'll be a tetralogy of Fallot, which will be characterized by a tetralogy of there'll be an overriding aorta, pulmonary stenosis, right ventricular hypertrophy, and ventricular septal defects. We will look at that another time. Now, let's look at non-shunt anomalies. Now, some congenital anomalies obstruct vascular flow by either narrowing the chambers or the valves or major blood vessels. Now, a malformation characterized by complete obstruction is called an atresia. So atresia is complete obstruction, but stenosis is a narrowed vessel. Stenosis is so a stenosis is incomplete obstruction, but atresia is complete. Now, in some disorders such as the tetralogy of Fallot, we have the obstruction, an incomplete obstruction. The pulmonary stenosis is associated with a shunt, a right to left shunt, and this will produce cyanosis. Now, other shunt anomalies include tetralogy of Fallot, mind you, is the shunt anomaly. Okay, but it has also some features of non-shunt anomalies. Now, some purely non-shunt anomalies include ectopia cardis, where the heart lies outside of the body. It does not lie within the middle mediastinum. Coarctation of the aorta, and dextrocardia. Dextro means to the right, so the apex of the heart is located towards the right side. Now, the altered hemodynamics of congenital heart disease usually lead to chamber dilation, okay, or wall hypertrophy. However, some defects may result in reduced muscle mass or chamber size. And if this happens intrauterine, that is known as hypoplasia. But if it happens postnatally, it is known as atrophy. Now, let's look at now acyanotic shunt anomalies. This is what now we the bulk of the session. Now, these are the left to right shunt, and they usually increase blood flow into the pulmonary circulation. You understand why? Because now blood will be moving from the systemic circulation towards now the pulmonary circulation now, and are not associated, at least initially, with the cyanosis. Okay, so At first, they are not associated with cyanosis because it is oxygenated blood which is moving towards deoxygenated. So there'll be no cyanosis. Now, however, they expose the low pressure, low resistance pulmonary circulation to high pressures and increase the volumes. And the pulmonary circulation is not adapted to these high pressures and increased volume. So it undergoes adaptive changes, and these increase the lung, the pulmonary vascular resistance, okay, to protect the pulmonary bed. Once this happens, there'll be right ventricular hypertrophy and eventually right-sided failure because of increased right ventricular afterload. Okay, so if you increase the resistance of the lung vasculature, there will be pulmonary hypertension, and this will remember when we said when we talked about right-sided heart failure, one of the mechanisms of pathogenesis was increased right ventricular afterload, which was caused by pulmonary hypertension. Now, with time, increased pulmonary resistance can cause shunt reversal. Okay, at first, if let me try to draw something here for you. Okay, so assume this is the left side and this is the right side of the heart. This is a right ventricle, left ventricle. Now, at first, blood was moving from the left to the right. Why? Because, as you know, blood in the left side has a higher pressure than the right. But with time, there will be pooling of blood in the right ventricle end. This will increase the pressure. And remember, the right ventricle pumps blood to the pulmonary circulation, but the pulmonary circulation is not adapted for this high pressure. So it undergoes adaptive changes to increase the lung vasculature resistance. So patient develops pulmonary hypertension, okay? And this causes the right ventricle will undergo compensatory hypertrophy, and eventually the right side generates more pressure than the left. So this shunt is reversed. So you have now a right to left shunt, and this is a cyanotic shunt. So at first the patient are acyanotic, but with time they can develop a cyanosis, and this is known as Eisenmenger syndrome. Please note that Eisenmenger syndrome. So let's look at some of these malformations associated with the left to right shunt. Now, disorders associated with left to right shunt are the most common types of congenital cardiac malformations, and they include ASD, atrial septal defects, VSD, ventricular septal defects, and PDA, patent ductus arteriosus. Now, ASDs typically increase only the right ventricular and pulmonary outflow volumes, but VSDs and PDA cause both increased pulmonary blood flow and pressure. Okay, now manifestation of this shunt range completely asymptomatic. When there is a left to right shunt, that can be asymptomatic, but upon shunt reversal or with chronic left to right shunts can result in a right-sided heart failure. Okay, so in this we have an ASD. You can see the septum here of between the right atrium and the left atrium is incomplete. So there is a ASD here, and here you can see a VSD where blood can move from the left ventricle to the right ventricle. And here you can see the patent ductus arteriosus now, where the blood will be moving from the aorta towards the pulmonary trunk. Okay, so you can see in all these cases, it is the blood is moving from the oxygenated bloodstream to the deoxygenated bloodstream. So this is a left to right shunt. No cyanosis, it is acyanotic. Now, let's look at atrial septal defects in patent foramen ovale. Now, during the normal cardiac development, you know that you have to maintain patency between the right and the left atrium, okay, by a series of fenestration, the ostium primum and the ostium secundum. Now, during interatrial septation, we usually first form the septum primer, which grows from the roof of the ventricle towards the endocardial cushions. Okay. Now this is the, imagine this is the right atrium, and this is the left atrium. Okay. This would be your ostium primum. Okay. Then with time, this septum primum usually fused with the endocardial cushions, but it undergoes apoptosis to form the ostium secundum. Okay, then you have another septum which grows from also from the roof of the atrium, known as the septum secundum, and it is usually thicker and to the right of the septum primum. Okay, and now this forms an oblique passage. Now that is what is known as foramen ovale. Okay, now this arrangement usually allow oxygenated blood to, from the maternal circulation to flow from the right to the left. Okay, that is normal in fetal circulation, but in later stages, after birth, the pressures in the left atrium rise, and they push this septum primum to fuse with the septum secundum, and this seals the foramen ovale. That is what should happen, but that happens in 80%. But in the remaining 20%, a patent foramen ovale results. Okay, so this allows transient right to left flow. Okay, such and this can occur during Valsalva maneuver. Valsalva maneuver is that maneuver you do when you are passing feces, a fetus, a flatus. Okay, so or during sneezing, okay, or during the bowel movements. Okay, now although this typically has little significance, it is occasional. It can manifest as paradoxical embolism, where a venous embolus, which originates from the right side, can end up in the systemic arterial circulation, okay, via that foramen ovale. Okay, now in contrast to patent foramen ovale, an ASD is an abnormal fixed opening. Okay, so unlike the patent foramen ovale, it is not fixed. It can open and close, but ASD is a fixed opening in the atrial septum, which allows unrestricted blood flow between the atrial chambers. Now, majority are so-called ostium secundum ASD. They arise from the ostium secundum, in which the septum secundum is insufficient to occlude the ostium secundum, or the second ostium. Okay, so I hope you understood that. If you didn't, maybe I can make a video on that. Now, let's look at the morphology of these ASDs. Ostium secundum's ASD, they form the majority, okay, and they are smooth word defects near the foramen ovale, and they are typically not associated with other cardiac anomalies, and hemodynamically significant lesions are accompanied by right atrial and ventricular dilation. You can understand why. Also, there will be right ventricular hypertrophy and dilation of the pulmonary artery, and this reflects the chronically increased volume load. Now, ostium primum ASDs account for 5%. They occur at the lowest portion of the atrial septum, and they are associated with mitral and tricuspid valve abnormalities. Okay, because of the close relationship between the development of septum primum and the endocardial cushions. Endocardial cushions are the ones which are involved in the atrioventricular septation. Now, in more severe cases, additional defects may include a VSD and a common atrioventricular canal. Now, sinus venosus ASDs account for another 5%, and they are located high in the atrial septum, and often they are accompanied by anomalous drainage of the pulmonary veins into the right atrium or the superior vena cava. So they are accompanied, they can be accompanied by the partial or total pulmonary vein anomalous connections, which can cause cyanotic congenital heart disease, the total anomalous pulmonary venous connections. Now, how do they present? Now, they are asymptomatic until adulthood. Now, although VSDs are more common, okay, and many close spontaneously. Many VSDs close spontaneously. Now, consequently, ASDs, which are less likely to spontaneously close, are the most common defects to be first diagnosed in the adults. Okay, ASDs initially cause left-right shunt. You know why, but they can undergo the Eisenmenger syndrome, shunt reversal. Okay, now in general, these defects are well tolerated if they are less than a centimeter in diameter. Okay, and even larger lesions do not usually produce any symptoms in childhood. Now, over time, however, chronic volume and pressure overload can cause pulmonary hypertension and shunt reversal. Now, surgical or intravascular ASD closure is thus performed to preempt the development of heart failure, right-sided heart failure, paradoxical embolization, and irreversible pulmonary vascular disease. Mortality is low, and post-operative survival is comparable to that of an unaffected population. So once detected early and treated, the patient generally becomes fine. Now, VSDs are defects in the ventricular septum. Now, if I can discuss interatrial septation, interventricular septation, how it occurs, the interventricular septum has two parts, a muscular portion and a membranous portion. Okay, so this membranous portion arises from the endocardial cushions and the valvular ridges. Okay, so these defects in the ventricular septum allow left to right shunting and constitute the most common congenital cardiac anomaly at birth. Now, the ventricular septum normally is formed by a muscular ridge that grows upward from the heart apex, fusing with a thinner membranous tissue that grows downward from the endocardial cushions. Now, the basal or the membranous region is the last part of the septum to develop, and it is the site of approximately 90%. So most of the VSDs affect the basal or the membranous part. Now, most VSDs close spontaneously in childhood, but only 20 to 30% of VSDs occur in isolation. Now, the remainder are associated with other cardiac malformations such as pathology of Fallot. Now, morphology. Now, the size and the location of the VSD are variable. They can range from minute defects in the membranous septum to large defects involving virtually the entire interventricular wall. Now, in defects associated with the left to right shunting, the right ventricle is hypertrophied and often dilated. Now, the diameter of the pulmonary artery is increased. You can understand why, due to the increased right ventricular output and higher right-sided pressures. Now, vascular changes typically in the pulmonary vascular changes will be observed in the pulmonary circulation, and pulmonary hypertension is common. Here you can see this is a VSD. This is a hole in the atrial septum. You can see this is the membranous part. This is the muscular part. Okay, and you can see the trabeculated part of the atrium here. Okay, consisting of the trabecular crani and the papillary muscles. Okay. Now, clinical features of VSDs. Now, they may be asymptomatic. 50% of those in the muscular portion of the septum close spontaneously during infancy or childhood. Now, larger defects, however, usually result in chronic left to right shunting, often complicated pulmonary hypertension and right-sided congestive heart failure. Now, progressive pulmonary hypertension with the resultant reversal of shunt and cyanosis occurs earlier and more frequently with VSDs than with ASDs. So understand that. So Eisenmenger syndrome will develop faster in VSDs than in ASD. Now, early surgical correction is therefore indicated for such lesions. Now, small or medium-sized defect that produce jet lesions in the right ventricle cause endothelial damage, and this increases the risk of infective endocarditis. Now, let's look at the last Acyanotic shunt anomaly, which is patent ductus arteriosus. Now, the ductus arteriosus usually arises from the left pulmonary artery and joins the aorta just distal to the origin of the left subclavian artery. Now, during intrauterine life, it is important because it permits blood to flow from the pulmonary artery to the aorta, so bypassing the pulmonary circulation, because intrauterine, the fetus does not use the lungs to breathe. Now, within 1 to 2 days of birth in healthy term infants, the ductus constricts and closes. Now, these changes occur in response to 1, increased arterial oxygenation, 2, decreased pulmonary vascular resistance, 3, declining local levels of prostaglandin E2. Now, complete obliteration occurs within the first few months of extrauterine life. Now, leaving only a strand of the residual fibrous tissue known as the ligamentum arteriosum. Now, ductal closure can be closed, can be delayed, okay, with hypoxia, okay. So, because remember, one of the reasons to closes is due to increased arterial oxygenation. So, in hypoxia, it won't close, and this can occur in the respiratory distress syndrome or heart diseases. Also, PDAs account for about 7% of congenital heart lesions, and the great majority of these are isolated defects. Okay, so clinical features, how does it present? Now, PDAs are high pressure left to right shunts that produce harsh machinery-like murmurs. Now, a small PDA generally causes no symptom, although larger defects eventually can lead to the Eisenmenger syndrome, the shunt reversal with cyanosis and congestive heart failure. Now, high pressure shunts also predispose the patient to developing infective endocarditis. Now, where isolated PDAs should be closed as early in life, okay, in some cases, there is need to maintain the ductal patency, okay, such as when the patient presents with transposition of the great arteries, there is need to maintain that patency, okay, and this is done by administering prostaglandin E, okay, alprostadine, okay, and because in transposition of the great arteries, the PDA is the only means to sustain systemic or pulmonary blood flow, okay, and also in aortic or pulmonic atresia. So I think that was it, and thank you for your time, and follow for more of this series of cardiac pathology. Thank you.